So this is my disclosure. My subject is using GLP1RA and dual peptide in lean Indian type 2 diabetics. So it's what I am going to address in next 15 minutes is about what is leanness or a normal weight, glycemic efficacy, which is a big challenge in diabetes clinic for majority of our patients, drugs to select out of GLP-1 class. We have more than half a dozen molecules, cardiorenal benefits, and other benefits. We are a little being taken away by great weight loss, which happened with a new generation or a second generation GLP-1RA. So if we look at how our patients are, this is Dr. Nitin Kapoor from CMC Vellore, and his review of multiple studies show that at a normal weight, Indians have, we mix up with obesity versus adiposity. For years, we used the word called obesity. We should be rather using an adiposity. And this is what 32% of Indians have at a normal weight, obesity. I am 7 kg underweight, 22 or 23 BMI, but my adiposity is still at 22% ideal, has more visceral fat all on the belly. So our patients are like that. Most people have in diabetes a higher adiposity. If you look at this particular finding, 2.5-fold increase in diabetes, hypertension, and dyslipidemia simply with normal weight obesity. Again, I don't like this word obesity, but adiposity, and you can see that risk factor presence is similar to obesity. This is another paper which is from India, which looks at 62% of diabetics have sarcopenia. So we have to again focus between amount of fat in the body versus amount of muscle. So balance between fat and the muscle will decide. So if there is sarcopenia, automatically the adiposity would be higher. And this is 40% have sarcopenic obesity. And these are metabolically unhealthy people at higher amount of fat. If we compare with European phenotype, this is same degree of adiposity, but our muscle mass is much lesser. And as you can see in this particular diagram, as our so-called phenotype moves from A to B to C, with every increase in adiposity, there is increase in insulin resistance, which decides the treatment and an outcome and a long-term morbidity and mortality in diabetic people. When we look for an ideal drug to manage diabetic people, each drug so far addressed one defect. For years, we controlled glucose without having impact on body weight, blood pressure, lipid, or leave aside inflammatory markers. We could never control the food intake of diabetic people. We probably needed a drug where food industry is so powerful in creating kind of a food, and we wanted to switch off a kind of a food consumption. So when we look at treatment of diabetic people, how much A1C reduction is required? How does a dual peptides or a GLP-1RA would behave in relation to so-called reduction in A1C without causing weight gain, hypoglycemia? Most importantly, also being well tolerated and affordable. It's a long-term treatment for diabetic, which should run beyond 5 years and not for short term. So let's examine some of them. This is lead 6 study, which looked at comparison of first two GLP-1RA, exenatide versus liraglutide. Exenatide ideally should have been 3 times injectable, and so it performed not so well with liraglutide. So this is 3 kg, close to 3 kg weight loss at highest dose of liraglutide and an A1C reduction. Look at a lead program, 6 different trials, baseline between 8 to 8 and 0.8. So at a modest higher A1C, it could still reduce HbA1c up to 1.6%, many times around 1.2 to 1.3%. So this is what is max what you might achieve. Only couple of drugs in few settings may give you, but if your patient has high baseline, 9%, 10%, and 11%, when you start a first injectable treatment, you would get higher A1C reduction. This is lixisenatide, which is still available in combination with a glargine insulin. And this was also similar, close to 3 or 4 kg weight loss with 1.2% A1C reduction, but liraglutide at highest dose offering 1.8%, 2016 Diabetes Care publication. If you look at a new generation weekly, the first weekly agent, dulaglutide, a very close match, 1.4% between highest lira versus dulaglutide and a 3 to 3.5 kg weight loss. So this kind of a weight loss, we will have to take it at a normal weight, so-called lean BMI diabetics. Let's examine award program of dulaglutide similar to lead program of liraglutide, and this is kind of an HbA1c reduction. Baseline is just 8.1% here and up to 1.4 or 1.5% A1C reduction, which is quite decent or a max compared to any other OAD so far. Look at the weight loss. If you are worried, it does not give you more than 3 kg weight loss at significantly higher baseline weight of 90 kg. So you need not worry. Diabetics in general lose much lesser weight than an overweight people. And at an Indian normal or a lean, I would say they would be somewhere around 60, 70 or 75 kg, would still lose lesser weight than this. Select patient may lose more weight. You will have to be careful in those people. Let's examine an semaglutide at the highest dose oral. Oral semaglutide is different from injectable semaglutide, and here you have similar A1C reduction of 1.1 with 3 kg or a 4 kg. Again, relatively a recent pioneer program of oral semaglutide. Across different clinical trials of oral semaglutide, 19 trials, 6,000 patients. If you are looking for a larger A1C reduction, you have up to 1.5% A1C reduction, which was there with dulaglutide in some trial, also with dulaglutide in some trial. So all three, lira, dula, and oral semaglutide, stop close to 1.5% A1C reduction as a glycemic efficacy at a modest 8 to 9% A1C baseline. If your baseline is higher, there would be more weight loss. A weight loss with oral semaglutide is marginally more than what you would see, which is going up to 3 to 5 kg, again matching with previous all different clinical studies. This is 1 milligram weekly injectable, globally well known as Ozempic. This is the dose in India as the Wegovy, 1 milligram. That is the third higher dose. Comparison with liraglutide 1.2. Novo's clinical investigation, why they selected 1.2 and not 1.8, but again 1% versus 1.7. So injectable SEMA at 1 milligram could give you a little higher A1C reduction, but of course a higher weight loss of close to 6 kg, which may be okay for some diabetic, may not be for some diabetic, because the title of my talk is a lean or a normal weight. The magnitude of A1C in a grossly uncontrolled diabetes, a published paper, but in an ADA poster in 22, they looked at a very high A1C reduction, 3.2 to 3.5 with tirzepatide, 2.6 with diabetes dose of weekly semaglutide, 2% with degludec, 2% with glargine. So if a baseline is higher than 9, probably you will get a larger weight loss with any of the drugs. Finally, going beyond glycemic efficacy, most of our patients with adiposity will have kind of more than 70% will have a so-called atherosclerotic cardiovascular disease and a presence of comorbid factors which would result into eventually cardiorenal disease. And so the benefit of GLP1RA beyond glycemic efficacy would be at all levels of mediation of cardiovascular and renal disease. And this is what was seen in a leader trial, 1.8, 4 years follow-up, 14% risk reduction seen, but a major benefit was on atherosclerotic or an MI or a stroke rather than a heart failure or a mortality. A sub-analysis of this particular leader trial for renal outcome also showed a 22% risk reduction in renal outcome and a renal endpoint, though it was not a dedicated renal trial, but a similar benefit. If we go beyond, this is all 13 CV outcome trial with GLP1RA, 83,000 patients, uniform, irrespective of homology of a GLP1 molecule, structure, different design, different patient population, but a universal 14% risk reduction for 3-point MACE. A beautiful paper by Navid Sattar, including a relatively recent trial, also has exactly 14% and 13% mortality, but a larger stroke. If you have seen the previous talk, SGLT2 inhibitor had hardly any benefit on stroke, which is visible in here. Probably a different renal cardiovascular endpoints get addressed with GLP1RA. Similar 22% benefit in a renal outcome. If you see the amount of weight loss, this is a large analysis, relatively recent paper done by UT Southwest, elegant design of looking at liver fat. And this, they concluded that compared to the total body fat reduction, amount of fat, hepatic fat reduction was much larger. 9.6% body fat reduction, but 12.4% liver fat reduction. So larger hepatic effect, and this is proven with liraglutide, but this is a 3 milligram study specifically done to see how much is the benefit on a hepatic fat. If a drug, by and large, by a class, reduces body fat as a core main mechanism, then obviously there is an anti-inflammatory benefit seen in different studies, pleiotropic. This is seen in a pulmonary fibrosis, in asthma, in long-term trial. A benefit for a long-term prevention of Alzheimer or a Parkinson. Benefit in patients who are treated with antipsychotic drugs. All GLP-1RA have an anxiety precipitating effect in the first month. But in long term, when drug is continued, it has an antidepressant property, which is unlike all other obesity drugs. Finally, this is again a paper in relation to plaque stabilization. Is it a new statin born? So this is again a new pleiotropic effect. 38 studies having kind of effect on a gut microbiota. So we are learning far more about a new GLP-1 research which shows that patient has to continue for long-term GLP-1RA to get the benefit. And this is what needs to be patient to be educated. So we should look much beyond weight in relation to all the other benefit and affordability and long-term sustainability of GLP-1RA treatment in type 2 diabetes. Thank you.